secondary trauma. And person by the name of Carla Joinson, who you will see referenced, the person who coined the term compassion fatigue, sent a letter to our clinic saying, we think a lot of what you're doing is very similar to what we're doing. And it really introduced the concept to us. And our manager, the director of our program, wrote the first book on compassion fatigue. So really happy to be part of it. So it's a concept that is really a nursing concept. It did not start in the mental health world. It started particularly in critical care and emergency room nursing. And so it has really, thankfully, become important for all of us. So I like to start with the current slide that under normal circumstances, well, what we do is really hard. And that as addiction professionals, and it's really interesting. We tend to see therapists and maybe techs as the group that tends to have the most compassion fatigue. And we have found in looking at the research that anyone in an organization who interacts with people who have significant trauma or works in an organization that's going through a lot of changes has a significant potential for burnout. So it doesn't matter where you work in the organization. If you hear stories about trauma, if you're working with difficult clients who, rather than saying are unmotivated, I always define them as highly motivated to stay safe. Stories of relapse and death, stress and turnover and all of that. The typical frustration with insurance companies, all of those things that under the best circumstances try our patience, try our coping, and now we add a pandemic, and that it tries us even more. So we are, in my mind, addiction counselors, I think, have the highest likelihood of having compassion fatigue because of the complexity in what we work with. And it's not just the counselors, but admissions folks, anyone that has to do with marketing and the stories that you hear. So why is compassion fatigue important? And just looking at some statistics, that in the last year, 47 million Americans have quit their job. I have never seen I've been in the field for 40 years. It'll be 40 years on April 1st. And I've never seen anything like it with the staffing shortages, people working with, bare bones staff that's exhausted, staff that's, just overwhelmed. 84% of all of those people who have changed jobs reported that they changed their job because of their mental health, because that it had a negative impact on their mental health. Another 50%, or not another 50%, but 50% claimed that they left their job for mental health reasons. If there's any administrators, certainly Tom understands the cost of replacing employees, the cost of dealing with burnout in employees. And so that when we look at the overall health of the organization, it starts with the overall health of our staff, but then it also kind of looks at the bigger picture of our organizations in terms of income and survival, and balancing the ledger sheets are important for our survival as well. And I would ask you to take a look at what's been the turnover rate at your organization. And I talk to people all over the country on a regular basis, and I always ask that same question: how are they doing? And everyone that I've talked to, certainly in the last 6 months, have been very clearly stating that the biggest stressor that they have is finding staff, that people are leaving without staying very long. So compassion fatigue, I was reading an article about hospitals, and hospitals spend somewhere around $7 or $8 billion a year in replacing staff who have experienced turnover. That's a lot of money. And when they came down to it, they blamed or cited compassion fatigue as the #1 reason that hospital employees leave their job. And so, again, looking at the overall health of our organizations, it's important that we look at this. A lot of people want to have a discussion about why is compassion fatigue not called empathy fatigue? And I think it's really important to look at the distinction between those two. And if we look at empathy, it's the ability to understand or be sensitive to our experience of what our clients are experiencing. And that the difference between empathy and compassion is the desire to alleviate it. When we start looking at burnout as a major source of compassion fatigue, it's not always doing the same thing over and over again. It's not always being frustrated by a new policy or procedure. A lot of times it's the persistent news of relapse or news of a death or someone leaving AMA. But compassion is empathy with a very sincere desire to assist or aid that person. So I think it's a much better mix to talk about compassion fatigue. Excuse me. I hope that makes sense. So Carla Joinson, the person I referred to as the person who coined the term, said that there are 4 things that are absolutely critical in terms of being aware of compassion fatigue. It's not just secondary trauma, by the way. That's what so often people say, oh, it's what we get when we get traumatized. And I'll explain that it's most of us, if our energy is good and we're exercising and experiencing good self-care, can manage the vicarious trauma that we get from our clients pretty well. But if we mix compassion fatigue or secondary trauma with burnout is where we really begin to get into problems. And I'll explain that in the next slide. But Joinson says the first one is that compassion fatigue is emotionally devastating. And think about how much sadness we work with, grief, depression, exhaustion, and how we experience those same feelings. How often we leave our offices or our facilities and are just heavy with the cost of kind of working with our clients. The second is our personalities lead us to it. I tell staff, if you don't have compassion for your clients, then you're pretty safe. You're never going to get compassion fatigue. And that's one of the signs of compassion fatigue is we begin to see a reduction in the amount of compassion that we experience. So you can't get it if you don't have it, but our personalities, the passion of everyone in this room to really assist others is a two-edged sword. It's what makes the magic of treatment happen, but it's also what makes it so burdensome for staff. The third, the outside sources of it, the cause that are unavoidable, the trauma and dealing with angry clients and the conflict that we experience, that those all have kind of an energy cost to us. It exhausts us, which makes us far more open to experiencing burnout, but also experiencing secondary trauma. And the fourth is the most important. The person who has it is the last person to know they have it. And so one of the things that I try to, if I'm working with a clinical team, is the relationship of the team is absolutely critical. But when we see someone who looks like they're burdened, when we see someone who is kind of going away emotionally, they may not have any idea other than what they're feeling. But we, as their peers and their friends, can do a remarkable amount of good by going to that person and saying, hey, we care about you. And, you used to have lunch with us every day. You used to kind of goof around with us at the end of the day. And, are you okay? And begin that process. And so if we leave it up to the person who has compassion fatigue to get help for their compassion fatigue, they will leave the organization in most cases before they do that. And that's our concern. And that's why it's so important to us. And then I would assume, I've had cases when I was a clinician and working with Vietnam veterans, I would have periods where, my wife would say, are you, she's also a therapist, are you okay? And I wouldn't put the pieces together, and just someone bringing it up to me and expressing, I care about you is significant to make that be of assistance. So you can see, the question of which comes first, the burnout or the secondary trauma. And again, different fields really don't see it as this combination. So I always use the infinity symbol and that recursive loop that kind of swings back and forth. And the idea that burnout is what we call organizational stressors. When policies and procedures and change and new staff members and constant training, the work that it takes to just be in our organization is really the cause for most people to experience burnout. Secondary trauma is what we call operational stressors. And those are the stressors that we experience in our day-to-day interaction with the people that we work with. And so what we have found over the years is it depends on your circumstances. In most cases, people begin to experience burnout, which exhausts them so that they have a harder time kind of knowing where they end and their clients begin. And so increased stress and burnout and exhaustion will usually lead to vicarious trauma or the increased risk for secondary trauma. And then there are times we have those cases that are so severe or so traumatized and their stories are so distressing and their pain is so palpable that we can actually experience, the DSM has added a fourth criteria for what causes or what are the circumstances that kind of lead to post-traumatic stress. And the fourth one that they added is that anyone who works in a work environment in which they are confronted with the realities, feelings, pictures, stories of trauma throughout the course of carrying out that job. And of course, it was written and included for police officers and firefighters. But when I think about families of traumatized clients, they often have the same thing. And when I think of us as peers, we're dealing with that on a daily basis. So it can be burnout first, or it can be trauma first. Now, if I've been traumatized, then I'm probably going to have a hard time getting to work every day because I'm going to be triggered by my office. I'm going to be triggered by my clients, and it makes it harder and harder to do that work. And so we're going to look at some tools that you can use to assess staff or to have staff self-assess themselves. And it's going to spend an equal amount of time on both of those areas. Okay, so burnout. So what is it? Most people tend to think burnout comes from doing the same things over and over again. And that's really not the case at all. There are people who have had the same job for 50 years and are just as happy doing it as they did before. Burnout is really about the negative effects of the work environment, meaning the stress, the trauma, the disagreement, the uncertainty, those kinds of things. So burnout is a state of physical, emotional, and mental exhaustion. And a guy by the name of Kotler wrote a book for counselors, and I always loved the comment that he made. And he said, burnout was never the right name for it. It should have been called rust out. And rust out is, it better represents the slow and gradual process that eats away at a caregiver's spirit. And the problem with burnout is that it is really slow to materialize. And that one day someone just realizes, I probably need to get a different job, or I probably need to leave the field. And so personally, on a personal level, the more burnout someone has, the less job satisfaction or compassion satisfaction they have. So again, that's the major reason for and in the addiction field, that is absolutely the case. Absolutely the case. I'll show you some research here in a minute. On an organizational level, the more employees in your organization who are experiencing compassion fatigue or experiencing burnout are going to see their employer as toxic. And so the idea that if I work in an organization that's highly stressful, and as a manager, I don't address that with my employees, my turnover rate is going to be significantly higher. The employees are going to be talking to each other about the toxicity of the workplace. So, that idea of anyone who assumes that burnout is an exception rather than a very, very common experience sort of misses the severity of that. There are three things that really speak to what burnout is, and I think most people that I talk to when I do these presentations can relate to all three, or they can relate to people that they know who have had all three. The first is disillusionment. And so we know that disillusionment is kind of the belief that this isn't the place for me, or the belief that I'm not very good at what I do. So as people become more and more burned out, they begin to question. My dog's right beside me. I just wanted to make sure she wasn't eating my computer, my other computer. So the more we begin to experience burnout, the more we begin to question whether I'm very good at my job. And so people who have, someone once said, people who have compassion fatigue can't leave their job behind. People who have burnout can't wait to leave their job. And so I think that's one of those really nice little assessment tools that people can use is, am I really looking to leave? Or when I go home and should be playing with my kids or could be playing with my kids, I'm really thinking about that client, did the discharge get set? And so people work harder. They believe that the only way they're going to be successful is to sort of become workaholic, if you will. And so the other thing that relates to that is, and it's really important for, and I do this with interns that I work with and with new counselors, is really an assessment of why they got in the field. And the research would tell us that the greater the imagined success and influence that staff have when they come into the field, the greater the potential for disillusionment. And I think of students who leave a master's program where they were empowered to come up with a model of care, and then they go to a treatment center that has a very clear model of care. And so they don't get to do the things that they're really impassioned to do. So they become more disillusioned with work. The second of the three dimensions of burnout is exhaustion. And it's related to the need for services and the neediness of our clients. How much paperwork do we have? How much customer service are we doing? And how much time are we spending dealing with complaints, concerns, just all of that, that even if we're appropriately staffed, we may be really exhausted from just the day-to-day expectations of our work. But given the fact that we're all working with staff that short-staffed, we would expect that our staff is exhausted on a regular basis. And then the last is cynicism. We've all worked with that person who is the first one to, come up with the, gallows humor, the first one that gives a passive-aggressive comment. Cynicism results from the unrealistic expectations and lack of resources. Cynicism is a staff member who is really angry about their circumstances, but recognize that they cannot be openly angry. And so they become passive aggressive or more, the term that someone once used that I thought was really good was thinly disguised contempt. That idea of, I'm angry, I don't feel like I have the resources to verbalize that anger directly. I don't feel safe to say what I think is wrong. And so they tell rumors, and they have conflict with other staff. They become like cynical. And I once, when I was at CU, I once sent one of my interns to a mental health center in Denver. And the student came back to the first internship class and she said, I'm leaving the program. I said, why would you leave the program? And she said, if I'm going to turn out as negative as the staff members are that I met in the last few days, then this is the wrong field for me, which opened a great discussion about burnout and compassion fatigue and how we're all susceptible to it. So if you put those three together, they make such really, they make perfect sense. It takes a lot of energy to go to a job where I don't feel empowered. It takes a lot of energy to go to a place that I don't feel I'm doing a very good job. And that the longer it goes, the more exhausted I get, and the more frustrated and angry I get. So burnout isn't just stress. A lot of times it's really dissatisfaction. I'm not going to go over all of these. I'm happy to send all of this to you, but these are the things that research would tell us that employees will cite as primary sources of burnout. Lack of control in the work environment, the idea of I have a lot of demand, I'd like to be able to do this job the way I think would simplify my life, but I have all of these things that I have to do to cross T's and dot I's. So high job demand and low control equals poor employee health and poor morale. Lack of empowerment to make decisions, a lack of collaboration. Sometimes too much collaboration is equally as troublesome. Poor communication, too much change. And think of COVID and how much we changed, and masks and telehealth and all of the things that I don't know about you, but I never thought I'd wear a mask doing therapy in my life. And suddenly, I just did a session without a mask on, and I wasn't sure how to do that. So insufficient reward. So these are what we would call organizational stressors. And so I do a presentation for managers that really helps them begin to understand what they can begin to do to reduce this organizational stress, to reduce the likelihood of burnout. And I don't cover those materials in this presentation, but if you're, if you have a manager that is really looking for that information, I'm really happy to send that to you. I actually have a video that I would be happy to link to my YouTube channel that is a YouTube on compassion fatigue, that if your organization want to do a little lunch and learn to be able to kind of educate the staff, I'm happy to send that to you as well. So secondary trauma, we'll talk about the kinds of secondary trauma, but a couple of things that I want to really kind of clarify. And if you look at the pictures, you can see a therapist talking to a young client, and we all know how that works. But secondary trauma is really that therapist's experience in working with that client. And so when we look at that client's posture, and she's talking about something really difficult, so it doesn't mean that the therapist has been traumatized, but it means that they are either vicariously, or I've heard people refer to it as infectious, like the idea of the more I work with traumatized clients, the more likely I am to have it. And so that's the first. And the second is that it's not linear. It's really recursive. It's really, it's a systemic process, because if you look at the second picture, that therapist has a family, and that therapist has team members. And the more impacted this person is as the member of a team and as the member of a family, when we get to the symptoms, is we're now going to have a recursive process, because this person may now start experiencing some issues in their relationship, or issues with their kids, or issues with friends and other companions. I've heard I used to work a lot with nurses when I worked in hospitals, and they would say things like, I used to exercise, I used to run, I used to dance, I used to, do whatever. And I'd say, well, what do you do now? And they'd say, I watch Ellen. By the time I get home, I'm so exhausted. And it takes a lot of energy to be in intimate relationships. It takes a lot of energy to raise and be with kids. And so to see this as a linear process of this person working with this person is only part of the story. It's this person impacted by her work with this person, and how that impacts their family, how that impacts their coworkers. It's one of the reasons people with both secondary trauma and burnout leave their job, is because they don't necessarily see that it's them. They see that they think it's the environment that they're in. So the first kind is vicarious trauma. That's what everyone kind of understands. Single member of any system is affected to their regular contact with traumatized individuals. And again, most of us are pretty good at working with a lot of trauma. We've had a lot of training, we understand self-care. But when burnout is added to that picture, or when we're dealing with maybe a very high caseload of traumatized clients, that the reality of vicarious trauma, the infectious aspect of it, is really significant. And the thing that's really interesting is that if I don't seek out social support and the ability to talk to people about that, the only place I have to go is home. I once had a nurse who was a pediatric intensive care nurse say, I just once wish my husband would acknowledge my sadness when I come home from work. And she said that he did it one day, and she started telling him about the death of these two children, and he was so dissociated, she realized, hold on one second, I gotta settle down. She realized that she had to deal with it alone, and that's clearly not the case. The second kind of secondary trauma is one you've probably never heard of. It's called chiasmal trauma, and it may be the death of one client who was really well known by everyone in the organization, and how the death of that client impacted every single person. And if you look at that circle that I have on the page, that's an example of a case that I worked with at another treatment center prior to the Foundry. And we had these two clients who came in on the same day to the detox. They went through detox together, they went through residential together, they went through PHP together, and they went through our IOP together. And they had become best friends. And one day they were living together in an apartment, and the one client came home and found his best friend hanging in the closet. And so when he called, immediately took care, called the police and did all those things. But when he called us to talk about it, it really traumatized everyone in our organization. And so I was trying to decide, we wanted to debrief everyone, and we were kind of talking about who should we debrief. And when we looked at it, if the person went through every department that we have, and their family went through the family program, and they talked to our business office about billing, that it literally, the death of one client impacted every single individual in our organization. And so that's why I say, when we're going to assess for secondary trauma or chiasmal trauma, we have to make sure that we really include all departments, because oftentimes we won't think that they were very impacted, but they may have even small impact can be really significant. So keep in mind, both the kind that therapists get, or that we get from just our daily work with clients, and then the real impact of really significant traumatic events on the whole organization. So who's more, how do people, what are the risk factors? And so there are very clear personal risk factors for compassion fatigue. The first is a personal trauma history. So if I had trauma, in my childhood, anyone who's heard me kind of speak, our son was hit by a car when he was 5, and he's fine as an adult, but that trauma still impacts us. And I have to be really careful when I'm working with certain kinds of families with certain presenting problems, because they have the potential to really remind me of our situation with our son. So that idea of personal trauma history. And I will add, has that client done their own work? Or not client, has that staff member done their own work? Do they not only have a history, but are they aware what it is? Are they aware of the symptoms so that they can begin to seek assistance when they experience them? Pre-existing psychological disorder. It's really interesting. New professionals tend to be much more impacted by compassion fatigue than people who have been in the field for a long time, and that they, over the course of time, has figured out how to manage that. Where new employees, new counselors come in with very high expectations and beliefs of the change process. So be really careful with your young staff, your new people who are new to the field. And I would add, techs, admissions folks. I think admissions folks probably have maybe the highest kind of susceptibility for compassion fatigue in the different states that folks are in as they're calling, dealing with terrified families or angry families, so much emotionality. So this is a group that often may say, well, we're not therapists, we don't deal with trauma. But if you're working in admissions, you're working with trauma with every case, or at least you're working with the symptoms of it. Isolation, inadequate support. That's one of the symptoms of compassion fatigue, that we begin to isolate. And it's also interesting that anyone who's had a significant loss in the last 12 months, whether it, and it doesn't seem to matter what that loss is, needs to be particularly careful. From a personal or professional perspective, the one I put at the top is, I really think, the most important: the lack of quality supervision. And so I have a slide at the end of this. So often we're so busy that supervision takes a back seat, or it's really about, we're going to talk about the problems that people are having. But there are different kinds of supervision. And one is called restorative supervision, the idea of, like, how are you doing? And if they're struggling, finding ways to help that employee kind of find coping strategies or whatever it is they're dealing with. The second, a high percentage of trauma survivors in their caseloads. And I'll show you some statistics in that area of just how significant that is in addiction. Relatively new to the field, we've already talked about that. Worker and organizational mismatch. I teach CAT classes for Colorado Mountain College. And it's really interesting, as people are coming into the field, how initially different each kind of student's beliefs about the nature of addiction, the causes of addiction, disease or not disease. And I spend a lot of time helping them to understand that they really need to know the organization's philosophy, or there will be a significant mismatch and it'll run into ethical concerns. So that idea of, if I'm working in a place that I don't necessarily have the same beliefs in terms of etiology of the disease and interventions and things like that, then I'm probably going to be more stressed and burned out. And then the last one is inadequate orientation and training. So often, particularly now, since we're all running a little short on staff, we may put people on the floor of the unit with more responsibility than they should have too early, which creates a significant amount of stress. So, and I list there's a lot of research in this area. And so you can kind of look at the end of this, I have a whole list of references for you to review if you're interested. So this is a study on addiction professionals. They were studying NADAC members, 2009, so it's been a while. And they studied 242 addiction professionals. And what they found was, when they looked at how much trauma was in their caseload, 97% of the people that they studied reported that they had traumatized cases. 93 reported that 25% of their caseload are traumatized clients. If I had been asked, to make that assessment, I would have said upwards to anywhere from 50 to 60% of my clients. And so when they studied how much compassion fatigue or how much trauma symptomatology do the professionals have, is they found that 56% of all the people they surveyed had one symptom of PTSD, 28% had two, and 20% met the full criteria for post-traumatic stress disorder. And that 43% had intrusive thoughts about work when they were at home and trying not to think about it. 27 were experiencing significant detachment from others, meaning they were isolating. 30% reported emotional numbing or dissociation. 26 had sleep disturbances, and 30% reported irritability. And so when we look at those numbers, the amount of distress being experienced by, upwards to a third of the professionals that they studied doesn't paint a picture of the healthiest kind of workforce, that there is a need for us to begin to address the overall well-being of our staff and of our clients. So these are some of the consequences of compassion fatigue for addiction counselors. And this was the 2017 study. And they found that counselors, addiction professionals who were experiencing compassion fatigue seemed to fall into a set of patterns that minimize the effectiveness of treatment outcomes. And the first was that they tended to avoid traumatic materials shared by clients. And so they would avoid certain topics. They would shape the treatment plan where it talked about trauma in the plan, but when it came time to talk about issues that triggered them, that they would begin to avoid it, thus preventing their client from working on key issues. Minimizing what clients reported in terms of their trauma experience. And it's not taking it as seriously, but an effort to be less impacted by really severe stories. I'll just jump through for time purposes. Experienced reduction in emotion or empathy. Therapists becoming more confrontational, less less empathetic. They really lose the ability to connect on that level. Higher risk of poor professional judgments, misdiagnosis, poor treatment planning. I did an article for the Encyclopedia of Trauma several years ago on the impact of research or trauma on researchers. And what I said in that was that what we found was that researchers, like therapists who are constantly dealing with traumatic material, had a really hard time with deadlines. They had a really hard time doing their paperwork. They had a hard time complying with documentation requirements. And we often see that with as one of the early signs of a counselor who has some issues with trauma or compassion fatigue, where they're not getting their notes done. Their notes might become more general and less specific. And so kind of food for thought when we look at the impact of compassion fatigue, particularly on addiction professionals. This is the turnover material that we were talking about, another study with NADAC members, and found that that addiction professionals who scored high on that trauma scale that we were kind of showing earlier reported significantly lower job satisfaction and occupational commitment. And that was the more trauma they experienced, the higher the turnover that they experienced. Even today, where trauma is everything, the statistics seem to be as consistent. The second thing they found was high job satisfaction mediated trauma scores. And so that if someone was working in an environment where they had a team that they really liked, they had a supervisor that they really liked, where they were able to find social support within that organization, that even it didn't matter how much trauma they experienced, they had much lower turnover. And again, that doesn't take into consideration COVID-19 at all. So Hope that's, I'm sort of, um, driving this point as hard as I can, the idea that this isn't just something that we have to focus on, do a little self-care. This is something that people really need to be educated on. So this slide, and then you can look at this slide, it's early warning signs of compassion fatigue. What are the things that, again, this every counselor in the United States should be educated on these. When they start having intrusive thoughts about clients, when they're sitting at home and they're watching whatever they're watching, and they're wondering whether that client is okay, how they did. Client stories become triggers for them. So sitting in a clinical setting, hold on one second. Sorry about that. Taking out work frustrations on one's partner, on their kids. Increased self-medication, food, smoking. I've talked with many therapists over the years who talked about they had been nicotine-free for years, and their way of managing the stress of work became to start smoking again. So there's a number of those that can all, and again, I'm happy to send this PowerPoint that you can share with staff members, supervisors, and kind of discuss that. So here are the symptoms that we would see. And so, they're very much PTSD symptoms, re-experiencing traumatic events. We've already talked about that. Always having intrusive thoughts about what happened at work today, intrusive thoughts about clients. A client, you get the message that a client had passed, and you begin to think about the interactions that you had with that client. The second is avoidance or numbing of reminders, a growing depression, more frequent dissociation, efforts to avoid, be disconnected from thoughts and feelings about work. It's really interesting. One of the first symptoms from a work perspective is not absenteeism. It's tardiness. And it's interesting how that works, and that employees will say, I know I've been late for work a couple of times, and I know I need to stop doing that, but so I get up an hour early, but there's always something to do and something I forgot to do, and that it's really an avoidant process of getting to work because of burnout and the secondary trauma. So paying really close attention to work performance issues such as tardiness, absenteeism, that we'll talk about in a minute. That these would be things that we would begin to see. The other one is on-the-job absenteeism. And on-the-job absenteeism is I'm at my desk, I'm working, and when I'm with my clients, I do fine. But when I'm sitting there with nothing really structured to do, I find myself really distracted, thinking about other things. And then I realize that I spent an entire hour that I could have been doing paperwork, not doing it. And now I'm behind the 8 ball with my, my paperwork and all of that. Diminished interest in activities. The research tells us that one of the first things, I talked about those nurses who used to dance and used to do those things. The first thing that tends to go are the things that take energy, but they're the things that give us the greatest joys in our life, whether it's exercise, cycling, things like that. And then the last one is detached estrangement from others, and the idea of difficulty with intimacy. Hopefully when we're distracted, the people in our lives, our partners will say, hey, what's going on? Let's talk about it. Are you okay? But sometimes this can lead to significant conflict in relationships as well. The third one is persistent arousal, anxiety, hypervigilance, irritability, or outbursts of anger. It's interesting, my research with traumatized families had a finding that said that the longer family members stay in fight or flight and sympathetic nervous system response, the less they focus on the normal needs and values of their family, and the more they begin to focus on vulnerability and safety. And so they may let work slide while they're trying to figure out if their loved one is safe. I think the same thing happens in the work environment, that the more we're in a high stress environment, the less we focus on the real needful things we need to do in our jobs and begin to focus on safety, conflict, whatever it is that we do to avoid. So irritability, outburst, struggles concentrating, startle response, medical errors. So those would be all symptoms of PTSD, but it's clearly in a much less intense way. And so the other thing I should have said it right at the beginning is that compassion fatigue is not like a disorder. Compassion fatigue is a reaction. And there's some things that we can do, and we'll talk about here very shortly, that if we do those things, that this goes away relatively quickly. And we'll talk about some of those in a bit. Here are some other symptoms. There are very clear physical symptoms, headaches, digestive problems, and that makes sense. If you're always in fight or flight, then the blood is not in the viscera, it's out in the arms and legs and brain trying to help you stay out of harm's way, and that it would make sense that there would be digestive problems. Muscle tension, needing to see chiropractors, begin to see injuries that from exercise where we didn't have injuries before, sleep disturbances, fatigue, chest pains, cardiac symptoms, not necessarily cardiac illness, but symptoms of high stress life, emotional symptoms, mood swings, restlessness, irritability, being overly sensitive to feedback, anxiety, excessive use of substances, anger, resentment. So there's a lot of those, hopelessness, helplessness. So you can see why people would be looking to leave the field or leave their job. Work-related symptoms, avoidance or dread of getting to work, avoidance or dread when they look and see that there's this one client that's on their agenda for the day, and they're already realizing that they're going to be triggered by that client. Reduced ability to feel empathy. A lot of this we've already talked about. Okay, so what do we do about it? So there's a lot of things we can do about it. And I think the first thing is to make a fairly clear distinction. Is this something that I should see a professional with? Is this something that I really, that maybe the trauma has gone from being a sort of a secondary kind of reaction to I'm having symptoms of secondary trauma or of trauma that I need to talk to someone about. And if that's the case, I always say that particularly addiction programs should offer some sort of employee assistance program, and we'll talk about those things in a minute. But so this is a kind of a 4-step wellness plan that I think really works well, and it works even better when people do it together, like when teams do it together. I was working with a organ and tissue donation company where they go in and after a person is deceased and collect tissues for everything from organs and all those things. And one of the things that when we were talking about compassion fatigue, there was this group within the organization that got really excited about it. And so they would set up like after work activities, and they would set up lunch and learns that gave people an opportunity to kind of take stock of what their stressors are, and to go bowling and do some of those things. So they began to develop a lot of peer-related self-care activities and education of all kind. Taking stock of your stressors, begin to assess your work environment. What are the things that you do well? What are the things that cause stress? What are the things that you probably need to talk to your supervisor about? The second one, looking for ways to enhance self-care. The fourth, developing resiliency skills. And then the last is making a commitment to implement change. And so, you know, I always like to compile lists of things, and this was a compilation of what employees that I've worked with have said, and a book on self-care and on vicarious trauma. But I just think it's a really good list. And maybe if you have a break room where you work, and that's where people eat lunch, you might want to take this and just put it on the wall, or put it by the sink or somewhere, to remind people that self-care isn't something that's done occasionally, but there's all kinds of things that we can be doing on a regular basis. The reality is that most people who engage in self-care experience less compassion fatigue, and doing it with other people has a greater ability to reduce compassion fatigue symptoms. And so things like physical care, eating healthy, exercise, getting massage, medical care, we're the worst patients. Like, anyone who works in hospitals struggles to go to the doctor so often. And I think it's the same for us. Taking time to be sexual, taking time to be intimate, self-acceptance and joining and connecting to others, getting enough sleep. The idea of, people need to stay up and work all night writing notes and doing all those things. We need to find ways to do those more effectively and efficiently rather than staying up all night. Take a vacation. When I was at Cedar, I think I left Cedar with 10 weeks of vacation because I never went on vacation. And so I'm a terrible example of how to do this. But the idea of, so often we're so short-staffed right now that when people say they want to take some time off, it's like, oh man, we don't have enough people as it is. But we need to find ways to allow people to take the time to refresh. Psychological self-care, time to reflect, write a journal, go to therapy. Look at not just the work-related stressors, but other stressors in our lives. And my favorite is being curious, try new things. We get so routinized when we're this stressed that we tend to lose our curiosity. Spiritual self-care, finding a connection. I'm sorry, our condo is being renovated and she needed to get out of there, but I need to get the dog real quick. Winter. Winter. Her name is Winter, and she is the perpetrator of this delay. So, this is a tool that I found that some people really like, is this beginning to fill this building block with little areas for change, like taking a walk every day, reading about nutrition. So these are just little tools that, like teams that work together in this process. I was working with some school teachers who were working with a really tough population. And one of the things that they decided to do was to meet after school every day and begin to walk on the track where they could begin to debrief. And what they found was, boy, they just, 15, 20 minutes, half hour of walking allowed them to go home and be really present. And so adding those kinds of things. So this is something that you could do a lunch and learn, where you kind of talked about burnout and stress a little bit, and then have people begin to look at what are the opportunities that they actually do have available to them. A lot of people will ask about resilience. And there's a great book that's called Resilience that was written by Southwick and Charney, both Yale professors, when they wrote the book. But they studied Vietnam veterans who were prisoners of war. And what they found was that there are very clear patterns that allow for the, like, we used to think that you were born resilient, or through your family and your parenting and attachment that you became resilient. And they began to realize that there were some people that through the process that you can see on this slide really built resilience. And that idea, and one day Steve Millett and I were looking at this when we were at Cedar, and he said there are so many parts of this model that are really consistent with like 12 steps. And the idea of, people who are really working a solid program may have some ways of, that's building resilience in and of itself. But having role models, kind of sponsors, people that you can look up to, and what would they do and how would they handle a stressor like this? A moral compass, the idea of, I know right from wrong, I know what I need to do, and being able to kind of do that. Cognitive appraisal, the idea of beginning to question my thoughts. Like if I'm thinking about leaving my job, and to be able to question, is that really because, I'm exhausted, or is that because I don't like the mission anymore? And really begin to question and talk to other people about what you're thinking and what you're feeling. Spirituality, optimism, social support, facing their fears. Can't think of, Stockwell was his name, I think was a general that talked about fear, and that all heroes are afraid. They just find ways to use that energy to achieve what they're trying to do. So facing the fears rather than avoiding them. Again, seeking supervision, talking with folks, exercise, staying fit, and then active coping. And active coping, how they describe it is, rather than talking about the things that I'm not going to do, it's talking about the things that you are going to do. And, when I talk to a client who's leaving the foundry and say, what's the plan? If they say to me, well, I'm not going to do this and I'm going to avoid that, and I know that that's bad, I think those are good. But when they say, these are the 3 or 4 things that I know I'm going to have to deal with, that are going to be the hardest, and here's what I'm going to do to deal with those, like that's a really good example of active coping. And that, we talked about, look at your stressors, look at the amount of trauma. How are you going to manage those? And then when we look at those, the more we do these things, the less likely we are going to be impacted by the trauma of our clients, and to be impacted by the burnout of our employer. So here's what I think. So those are areas that I just talked about for self-care. I think there are things that your organizations can do that are really helpful. Number one, anytime I consult with an organization on compassion fatigue, I have their CEO write a letter to every employee that says compassion fatigue is real. There's no way around it. People are going to get it and have it. And the best way for us to maintain the health of the organization is to really educate people and allow people to support one another, so that the organization is committed to addressing it. I have them do an organizational assessment, and I'll kind of show you and I can send you, there are a number of different ways you can assess your organization that I'm happy to send those. So if you, you'll see my email address, that if you're interested in those resources for your organization, I'm happy to send those. And then the last one is regular education for all employees, like new employees. So there should be at least a discussion of compassion fatigue with all new employees. I think a video like that video that I have, I'm happy to share, that new employees should see it and someone should debrief it with them. and to talk about, these are the things that happen here. These are the things that you're going to be dealing with. I think there should be an abbreviated version of this annually as an update. It's really effective to create support groups within the organization. Typically the rules of a support group is that they are member-led. If you're doing great, you should come to support the people who aren't. If you're not, you should come to get that support, and be really careful to not make them like, complaint sessions. And if it's a lot of stuff that really is kind of management driven, to maybe develop a committee to talk to management about those problems, but really an opportunity for people to support one another. I've done it at a variety of places that I've been, and when places I've consulted, and they've always been really, really helpful. And if you remember the organ and tissue group that had the really energized team, they managed those support group meetings. The management had nothing to do with those, but and they were very clear about what was appropriate and what wasn't. Create a wellness team. That's what I was just talking about. That do wellness activities, lunch and learns, bowling. We do something quarterly for our employees, whether it's, we have field day where they all do kind of weird, crazy sports events, three-legged races, and just stuff to make people laugh and to have some fun. We go to the, we have picnics out at the reservoir. There's a lot of things that get organized, and again, we have a group that kind of identifies those. Offer an employee assistance program. Allow someone to go speak to someone. We use a program called Bonusly, and Bonusly allows managers to give points to people where they can get small, buy small things in that process. They get employee discounts. We've worked in providing fitness centers with employee discounts. If you use something like Zwift or Peloton, our organization will pay for an employee membership to those, so that just as a way of keeping people engaged. We have not done this at Foundry for a while, but we really are going to begin and need to do that. But it's really helpful to do an evaluation of all employees. And so there are two tests that I really like. One is called the Professional Quality of Life Program. And it's a 36 question that assesses secondary trauma, it assesses burnout, and it assesses job satisfaction. And what I do, and then what you can see on the screen is an assessment identifying challenges in your day-to-day work environment that cause burnout, looking at the challenges that cause secondary trauma. What are some things that they can do? I have another assessment that asks people, what could the organization do to improve, to minimize burnout? And what we do is we have everyone complete it anonymously. If they want me to go over or someone to go over the scores with them, their scores, and to explain what they mean, they can, everything goes out in an envelope and they can put their name in there, and then I'll know to get a hold of them. And I use the scores and I use the information when I do the compassion fatigue education. And it's always more meaningful when we use the concerns that our own staff have. And of course, since it's anonymous data, people are more likely to be honest and more likely to give us those things. So from a management perspective, acknowledge that it's there. Assess the staff, all of the staff. Provide opportunities for self-care, provide opportunities for exercise, those kinds of things. and normalize the experience. From the individual perspective, working as a team on wellness, working as a team on kind of maybe working with management to reduce stress, to reduce some of the burnout causes. So I think that's the majority of that information. So you can kind of see these are the references. So here's my information. If you want me to send the information to you, and I'll send you a bunch of other stuff as well, I'm happy to talk to managers. I'm happy to talk to CEOs. If you find that this is something that would be beneficial, this isn't something that just Foundry needs. It's something we all need. So my email address is mike.barnes@foundrysteamboat.com. And my phone number is 303-885-1846. So, let me know anything that you would need, any questions that you have. And I think we have a couple minutes. Are there any questions that you would like me to answer?
Hey, Dr. Barnes. Yeah, we have one question. So the question is, how does shame play a part in compassion fatigue if someone who went into the helping field is now experiencing compassion fatigue? What options are in place to help address the shame that can sometimes arise?
That's a great question. And it's something that's very rarely talked about. So I think it's an even better question. I think it's critical. I think so I had made the comment earlier. It really comes down to, have we done our own work? And if we haven't, issues of family of origin. It's interesting. I was doing supervision yesterday and we were talking about clients will often try to put us into categories as like, you're my favorite counselor here, which is really a way of saying, please don't, please be nice to me, or whatever that they're trying to do, or, you're a bystander, you don't really care. And so the roles that we played in our own family of origin, that creates a lot of that shame, developmental trauma, with, you're not allowed to get your needs met, or, you're never quite good enough. If those are the issues that, we are living with in our head all the time, then when clients put us into those roles, if we're not really aware, oh, that's the role I played in my family, and therefore I need to, my countertransference is going to be something I need to pay attention to. So there was at one time in the early days of compassion fatigue that people were publishing that it was just simply countertransference. It was that kind of shame response, the lack of a sense of self. So first of all, be aware of our own issues, be aware of what are where we go into shame cycles, what are the kinds of clients that are the hardest for us, but also having people, again, to talk about, this has been so think about, if I'm if I'm with my wife and we're talking about something and I'm having a hard time, the best thing I can do is sit down with her and say, let's talk about what I'm feeling about our interaction. We can't do that with our clients. It's not like I'm going to sit down with my client and say, you said this and now this is my feeling. And so we may do some processing, but we need to have people to begin to do some reality testing. And it's amazing how quickly that tends to go away. And I hope that answers that question. Any other questions that anyone has? Feel free to send them to me as well.
What I was thinking, Dr. B, is if also I wanted to let anyone know that if you would like to get in touch with Dr. B and I think a lot of people here I have relationships with in our partnerships from treatment center to treatment center. I can help facilitate anything with him to come out and talk to your teams, like he said. But Dr. B, somebody asked about the slides. Could you email them to me and Marina, and then do we do a follow-up email sometimes, Marina?
Yes.
We'll get them out to
Okay,
people.
that makes it simple. I can
Mhm.
do
Let's
that.
keep it real simple.
And I'll probably remember to do that. Like,
I'm gonna text you.
it's an inside joke with Mel and I that she has to remind me of all the things I didn't do. So
You do a lot though. That's why I have to remind you. All right. So I just wanted to tell you, thank you so much, because this is all very important information. And then I do think, we have a hard stop at 1 o'clock, so we will wrap up. But I wanted to remind everyone on here to please pay attention to the April Facebook page and email, as we might be going in person for April, as soon as April. I think I said May earlier. And I believe we will, next month, it'll be more of a networking feel. And so if you are coming and plan on it, like we said, same time, either virtually and or in person. And I'm thinking in person for the month of April. So that will make it, I'm going to go ahead and look at the date. Sorry, April 6th. Wednesday, April 6th at 11:30. And all that information will be out at the end of this month. And thank you. Anything else? Are we good?
I apologize about my dog, just saying.
Don't worry about it. We're all moved past our dogs and our kids. My kid had a complete meltdown on a Zoom with Dr. Barnes, and I wasn't even working with him yet. About 2 years ago. So I think that, like, my dog was looking for your dog during that, which was really entertaining for me. And I wish he could talk, but we're all used to these things by now. Dogs, kids, whatever. The more the merrier.
Well, thank you.
Of course. All right. Well, thank you all and have a wonderful rest of your day. Hopefully everybody gets some sunshine in their life today.
Thank you.
Thanks,
All right.
everyone.
Bye.
Bye, y'all.
Thank you.
Bye.
Bye.